Thank you. Hello, everyone. Welcome to today's session. I'd like to express my sincere gratitude towards Poland Nutrition for using this platform where we can share our knowledge and thoughts on nutrition in CKD patients. So it's a very relevant topic these days in our daily practice. I believe you can see my screen. So today's topic is nutrition in CKD patient. We will focus directly on this. So the points today we will cover here, some introduction is there, then malnutrition in CKD patients, and the factors which are responsible for this particular malnutrition in CKD patients. We will focus on that. What all are the cause and mechanism of protein energy wasting, that is very important, and particularly need of protein and energy, how we will calculate, what the dose should be, that also we will know, and need of micronutrients also, micronutrients, electrolytes, water also we will focus on that, need of enteral nutrition in CKD patients, and what is our aim of this nutrition support. So definitely, once I'm done, I would like to hear from you people also. So abnormal kidney function, it's usually indicated with the broad term that is acute kidney injury, AKI we used to call, or acute kidney disease, or chronic kidney disease, CKD. It's highly prevalent among the hospitalized patients in different clinical settings. Like nephrology, we find this patient in internal medicine ward in our hospitals, surgery ward, or intensive care units is there. Here, ESPN guideline for adult renal failure and including screening, assessment, nutritional counseling, how we will arrange the oral nutrition support. All these things guideline is there. So first, let us know just brief on what the kidney disease is. What are the stages of kidney disease? Acute kidney injury, which occurs less than in 7 days, it's an acute condition. Acute kidney disease occurs in 7 to 3 months. But if it is chronic kidney disease, so it doesn't abruptly happen. It takes more than 3 months. It develops very slowly. So chronic kidney disease, our focus today's session's focus nutrition goal is on that. So it will be like, what is the kidney's function? When it is compromised, then what all works we are going to miss in our body? Just let me brush on that thing. Kidney, it has like 3 different dimensional function is in our body. Kidney, it works like it has some excretory function, then its buffering action is also there, and some endocrinal function is also there. As you all know, excretory organ kidney, it's mostly what all the nitrogen metabolism products are there, metabolic end products are like urea, right? So urea we get from the dietary protein. So after protein metabolism, urea is there in our blood, and our kidney helps to eliminate that from our body. This is the excretory function. Then there is a buffering action like body's acidity or alkalinity, pH balance, water balance. Our kidney helps to maintain that. And that the endocrinal function like hydroxycholecalciferol, that is, and with that renin, parathyroid hormone, calcitonin, these things are directly regulated by the kidney. So if the kidney function is compromised, our body is going to compromise on this function. So acute kidney injury, as I said, this happens abruptly. Abrupt decrease in kidney function that occurs over a period of hours. It could be in some few hours or less than in 7 days, which like it could be both structural damage or it could be some impairment in kidney function. Both of which can happen. But chronic kidney disease, that is the functional compromisation. So increase in serum creatinine level by 0.3 milligram per deciliter within 48 hours, and urine volume also get compromised, like it's less than 5.5 ml per kg per hour. That happens in acute kidney injury. So what we should set as our goal in if it is acute kidney injury? So to reduce the negative protein balance and prevent the protein energy malnutrition, to retain the lean body mass and maintain the normal body composition, to avoid the metabolic derangements and improve the biochemical parameters, to improve the respiratory function capacity and also the healing, and to improve the kidney function, to improve the overall outcome and reducing the mortality. This is our goal to set the nutritional therapy. Here you can see the guideline for the nutritional requirement for AKI patients. So as per ESPN guideline 2016, it's 25 to 30 kilocalories per kg per day body weight. And protein also, we will keep it down like 0.8 gram per kg body weight per day. Carbohydrate and fat as it is normal, like 3.5 gram, maximum 7 gram per kg body weight per day, and fat 0.8 to 1.2. Now coming to the chronic kidney disease. Abnormalities in kidney structure or function that persist for more than 90 days with or without decrease in glomerular filtration rate criteria. It's not like that initially GFR will go down. Not initially it could be normal, but once it is less than 60 ml per minute for less than 3 months or without kidney damage, so we will call it chronic kidney disease, where the function of the kidney is compromised. Glomerular filtration rate is going down 60 ml per minute. So what are the important specific metabolic abnormalities associated with AKI or CKD? So protein catabolism is there. Alteration of metabolism of specific amino acids are also there. Peripheral insulin resistance develops in body. Reduction of lipolysis and impure fat clearance is also there. There is some depletion of antioxidant system also, and induction of a pro-inflammatory state. Body is inflammatory, and definitely so immunodeficiency is there. So malnutrition in CKD patient is very, very common, especially in India. Malnutrition is characterized by the loss of protein and energy store associated with multiple metabolic derangements, most of which are pericular of the syndrome. Several metabolic and clinical factors may negatively affect nutrition status and lean body mass, also leading to fatality. So CKD treatment itself, such as, for the example, an appropriate dietary restriction or hemodialysis procedure, all these may play a big role. If urea is more in the blood, if the patient are nausea tendency is there, patient cannot take the food as much they should. And it's a hemodialysis, that's a very stressful condition. The factors responsible for malnutrition in CKD patients are inadequate spontaneous nutrition intake, anorexic patients, most patients are anorexic. Metabolic acidosis is there, insulin resistance develops there in our body, and chronic inflammation is there, intestinal microbacteria alteration is there, infection and oxidative stress, dietary restriction are also there, some myths are there. So especially we need to counter with that also, what all myths are there regarding the diet of a CKD patient. Cause and mechanism of protein energy wasting in CKD patients are like reduced protein and energy intake, hypercatabolism in our body, in the patient's body, metabolic acidosis, reduced physical activity, reduced anabolism, comorbidities and lifestyle, and dialytic treatment. All these things are responsible for protein energy wasting in a CKD patient. So here you can see This flowchart is there. Protein, energy, wasting, all like inflammation is in their body as we discussed. Reduction in nutrient intake, reduction in renal function. So uremic toxicity is there in body for which patients are getting anorexic. So guideline for protein requirement. That is very important because in CKD mostly we get two type of patients. Some patients are chronic kidney disease, suffering from chronic kidney disease, but they are within stage 3 and not getting dialysis, and some patients who are getting dialysis, hemodialysis. So in both of the cases, nutritional requirement is very different. For CKD patients, nutritional requirement, the diet, it should be principle, what we can say the principle. It's like fluid restriction should be there. And energy, yes, energy wise, it should be at least 25 to 35 kilocalorie per kg body weight per day. That means we have to deliver high calorie diet. Protein recommendation is something different. Like if the patient is getting dialysis, then high protein diet will be there. High protein. And if the patient is not getting dialysis, then it should be low protein. Now how much that is high protein and how much that is low protein? High protein, it should be 1.2 to 1.5 gram protein per kg body weight per day. Whereas if it is low protein, then it should be 0.5 to 0.8 gram per kg body weight per day. But in both cases, energy requirement, because the patient is in catabolic state, so patient requires more energy. High energy requirement is there. And electrolyte balance, that depends according to patient's serum potassium level, sodium level, and phosphorus level, that you need to take care, and accordingly you have to do the correction. So as we discussed, the same thing is in here. You can see energy also. Energy 30 to 35 kilocalorie per kg body weight per day. Now some question would be arise there, like if the patient is having diabetes mellitus, then what to do? Because if it is solely the patient is suffering from diabetes mellitus, then you usually restrict on calorie. But if a CKD patient suffering also from diabetes mellitus, then should we go for a high calorie? Yes, we should go for high calorie diet because the patient is in catabolic state. We need to counter with that. Along with, we will adjust the doses of insulin or medicine to counter with the high blood sugar level. Micronutrient requirement. Because of increased requirement during critical illness and large effluent losses occur, trace elements should be monitored and supplemented. It's not like that low potassium, low sodium. It should be monitored. If the patient is having hyperkalemia, then we have to correct that. If the patient is having hypokalemia, that also we need to take care. So we have to supplement it in both cases. Increased attention should be given for selenium, zinc, and copper. Water-soluble vitamins should be monitored and supplemented. Special attention should be given to vitamin C, folate, and thiamine. Timing and route of feeding. So as per ASPN guideline and ESPN guideline, early nutrition support, that is within 48 hours from hospital admission, and enteral nutrition over parenteral nutrition, that thing, so it's globally accepted, and we follow that protocol only. So in patients just like as a sarcopenia could be decreased and self-sufficiency could be improved. If oral intake if not possible, then only we will go for enteral nutrition in typically adult patients, and definitely we will target to achieve 70% of the targeted energy requirement. We will wait for next 48 to 72 hours. If we fail to achieve 70%, then we will think about for the parenteral nutrition. Otherwise, it's always good choice for going for enteral nutrition. So what should be the aim of nutrition support? Our aim should be maintenance or improvement of subjective quality of life of the patient, reduction of treatment-related side effects and complications, maintain strength, energy, protect immune function, decrease the risk of infection, aid to recovery and healing, and to shorten the hospital stay definitely. Adequate nutrition intake will maintenance and or improvement of subjective quality of life, reduction of treatment-related side effects and complications, maintain the strength, energy, protect the immune function and decrease the risk of infection, aid to recovery and healing, and of course adequate nutrition intake. We will encourage the patient. So IsoPro, Albu, IsoPro Max, IsoPro Peptide, all these things are there available in your hospitals, in your clinics to treat with the patients. Presence of like AKI, CKD with or without in hospitalized patient identifies widely varying nutrient needs and intake. However, since all these patients are at high risk of malnutrition, nutritional status should be thoroughly assessed. That is very important, and also nutritional requirements should be frequently evaluated in their quantitative and qualitative aspects to avoid both underfeeding and overfeeding, aiming to define the most relevant important aspect of nutritional support in different clinical settings of hospital patients with AKI or CKD with or without, and practical recommendations and statements were developed aiming to find the suggestions for everyday clinical practice in the individualization of nutritional support of this patient setting. So like kidney disease, there are parameters by which we need to go for a thorough nutritional assessment of a patient or hospitalized patient. What is the patient's creatinine clearance? Depending on that, we will calculate how much protein should be given to a patient. GRF, that will help us to assess patient's kidneys, in which stage the patient is there. So accordingly, we will correct the protein and energy goal for a patient. As we said, it should always be high calorie, high energy, along with fluid restriction to avoid the fluid overload, and potassium, sodium, phosphorus. These things are major elements that we need to take care and evaluate on regular basis. And in regular day-to-day practice, the patients we get, most of the patients are anorexic, are not able to intake sufficient food or sufficient diet. So we need to go for some supplementation to encourage the energy and protein requirement there. So it's always, we will encourage the patient to go with the normal food. But in cases it is not sufficient for a patient, then definitely we should go for some supplementation which will help the patient to achieve the goal for their nutrition target. And of course, in hospitalized condition, if we encourage this thing, once the patient is getting discharged and go back to home, they get some like, it's the mind setup, na? If this thing was in hospital, so when they are at home, they try to follow the same thing. There are some myths regarding this diet. Lots of restrictions are there. Some people are following this thing. Some like they are not taking or they are not going to professional persons, dietitians, doctors, they are just gathering some information from online, from Google and all these things. So myths are there and they are following that thing. Also, that is decreasing their nutritional status day by day. Most of the vegetables, most of the fruits, these things, everybody says no. But what actually is there? Patient is not like that. Always patient is suffering from hyperkalemia. If hyperkalemia is there, then we need to take care of that thing. But if the patient is in hypokalemia, then we supplement the potassium there. Then why not to go with all those natural things, natural food? So we need to educate patients. That is very important. Not only us, the professional persons, we also need to educate our patients also. So that helps them to stay back better. So definitely nutritional assessment along with that nutritional counseling of a patient on daily basis, that is also very important. And in our hospital also we focus on that, we emphasize on that so that we educate our patient also. So seminars are there, and some other time also, like as Poland Nutrition has arranged this session with the professional persons, sometimes they also arrange some session, or some other companies also sometimes they set program for the layman people, for the patients who are suffering in dialysis departments also, who are coming regular basis to us. So it also helps them to educate and to improve their nutritional status on day by day. So if you are having any question, so feel free to put down your queries.
Thank you so much, ma'am, for putting that much of light on CKD